Welcome to the program. I'm your host, Neil Howard, here on Health Professional Radio. Thank you for joining us today. Our guest is Brenda Doherty. She's a partner at Buffkin Baker. Buffkin Baker is an executive search agency that specializes in securing C-suite leaders for hospitals and healthcare systems. She's going to discuss with us today a gap in leadership when it comes to health management, especially concerning issues of ageism and women in the executive seat. Welcome to the program, Brenda.
Thank you for having me.
Great. Glad that you could take the time and join us. First of all, give us a little bit of background about yourself and then explain to our listeners what a C-suite executive is.
Of course. My background, I actually started my career as a nurse and had career progression into leadership positions, operational positions within healthcare, both public and for-profit organizations. Mid-career, I became a search consultant and have been in the role of searching and finding executives for the healthcare space exclusively since.
So a C-suite executive, what type of executive is that?
C-suite executives are the leaders of the organizations. They are the pinnacle of clinical leaders as well as business leaders for hospitals, healthcare systems. In healthcare, they're largely determined by clinical tracks as well as from a business operations. But you have your CEO, you have your COO, your Chief Operating Officer, you have your Chief Medical Officer, you have your Chief Nursing Officer, you have Chief Strategy Officers, you have Chief Financial Officers. So it is a group of people that lead and direct the organization.
And their titles seem to start with C. I guess that's where the C-suite comes from?
Indeed, it does.
What are some of the most sought after positions for these C-suite candidates? And are these positions the same for men as it is for women?
Well, it's an interesting question, Neil. And I guess the overall response is yes. Are they the same for men and women? But they're really driven and influenced by, as I said earlier, the clinical track one has chosen. For a doctor, it could be Chief Medical Officer or Chief Quality Officer. For a nurse, it could be Chief Nursing Officer, or it could be, and is becoming more and more these days, Chief Operating Officers, and hopefully Chief Executive Officers. So the one constant is the ultimate role for both male and females is CEO. What is different, though, is in healthcare, the experiences and the opportunities given to build a career that ultimately ends in a CEO position is different for males and females.
How is it different, and what are people doing in order to kind of close this gap?
Well, I think it's different for a number of reasons. First, what motivates males and females to executive roles, how they lead, and then most importantly, as I said, what opportunities they have had to build a career and a track record. And all of this, it's not an easy answer, Neil. All of this is influenced by social structures and practices where men have historically held the dominant roles. You really just cannot take gender roles out of historic context. Male dominance and female subordination are really the result of economic, social, religious, and cultural influences. And these have been going on for much of human history. So it's all evolving. But remember, women have, and they continue to get it done. And I think in healthcare, it's interesting, even though you still see most of CEOs male, but in modern hospitals, the Catholic Church was really the originator of such, and notably, they were all operated by nuns. So it's a complex answer to what should be a simple question, but there is not gender parity at the C level, and particularly at the CEO level.
Do you think that it's maybe the responsibility of healthcare to be the leader of closing this gap? And do you think that that would happen in the healthcare industry in the next few years? Or are we talking, 30, 40 years out?
I think it's a changing landscape, Neil, but it's not changing as fast as many of us would like to see. I think there was a study that was conducted by Rock Health, and they just queried female healthcare workers, and they found that most of them believed it would take 25 years or longer to achieve gender parity. But the sea of change is slow. I don't think that healthcare is essentially any different than any other industry in terms of providing opportunities for female leaders. So I don't think that is necessarily different. But it is changing. It's just changing slower than one would hope.
You mentioned several factors: religious, socioeconomic. Aren't those prejudices, preconceived notions, aren't they present when recruiters are looking to hire for executive roles, whether that recruiter be a male or a female?
That's a hard question to answer. Our social are just part of the human condition. I think recruiters really try very hard to work beyond those biases and really recruit based on hard data, experience, P&L responsibility, results. I think when you are able to really look at the hard data, that helps in terms of managing biases of any nature. I think, though, that what really does influence this more than anything, and it's often a chicken and the egg, Neil, is to get gender parity, to get diversity in any executive team. It really has to be driven by the board and the executives that are currently in these roles. And unless you have females the more females you have on the board, the more female CEOs you'll see. And the more CEOs that are female, the more female board members you will see. So it is a chicken and the egg, but I think there are things that can be done in order to push this forward in a more successful and faster way. In terms of the board, first, you really have to have socially or with mandates to the board that you have a certain number of female represented on the board. Secondly, is that stockholders can pressure companies, and I think when we talk about quotas or percentages that are required, I believe that Norway actually does this, where they require and have quotas for female board members. It starts by making it an issue, by identifying that we need female leaders. And then it starts by sponsoring, mentoring, training, and developing them. And then it is insisting that search firms bring diversity in terms of candidate slates. And then it may also require that boards bonus existing executives on prioritizing diversity and meeting diversity goals. So nothing really changes behavior, including gender imbalance, like financial incentives. The message that's most important to me personally, to send and professionally, is that I think these changes, in order to promote female leaders in every aspect of industry, is that it really begins at the cradle. And from the time of infancy, you have to instill through daily and repeated messaging that they're smart, that they're strong, and that they're leaders. And I think that when you do that, that's when you'll see a different generation that will appear and will be the leaders of tomorrow.
Just makes perfect sense. Well, thank you so much, and I'm hoping to talk with you again in the future.
Neil, it was a pleasure. Thank you.
You've been listening to Health Professional Radio. I'm your host, Neil Howard. Transcripts and audio of the program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to this podcast on iTunes, listen in, and download at SoundCloud, and visit our affiliates page at hpr.fm.